The subject line, LHD call question. Today's agenda will have the vaccination unit update, the modeling update, other PH ops, and then updates from local health districts and questions will be handled in the chat. Bob Moskoff will be joining the call around 11:30 to answer any questions through chat. So we'll squeeze him in there as he does come on the call. We'll go ahead and get started with the vaccination update with Marshall. Marshall, Vogt, are you on the call?
I am. Thank you so much. If we could go to the next slide, I'll go to today's agenda. Pretty light agenda today. We're going to be talking about updates for pre-registration and allocations, as well as some news about community vaccination centers, a couple brief PrepMod system updates, and then Jessie Silver will join us, and she's going to demonstrate the VACE, or Vaccine Appointment Scheduling Engine system. So if we go to the next slide, some updates on the pre-registration tool and the call center. We are continuing to collect pre-registrations through this centralized tool, and all of that existing data from local health districts is now entered into that. There is some cleaning and deduplication that still needs to happen, and we are aware of the fact that there are some delays as the system checks against VIS. So please be patient. We're working to optimize that, but the system will check against VIS, so you can see vaccination history for all of the pre-registrants, and it is checking against the VACE, or Vaccine Appointment Scheduling Engine system, so you know if they have been scheduled through that system. Again, there are some deduplication of records and merges that need to happen, and we are, the data team is working on that. Districts have access to that data, but if you need assistance or you have suggestions or comments or questions, please contact the data team, Carlos Rivero, Mike Sarkissian, Jesse, all of those folks. They are working very hard to try to make that system work for you as much as possible. The ability to verify pre-registration is once again live, and you can also now edit your pre-registration data. And we're encouraging everybody through press releases, and I believe Dr. Vula also said it at the press conference, to go in and edit that data and make sure that that data is all up to date, so that there are the most amount of data elements in each person's file for districts to pull from as they're trying to send out appointments for vaccines. To go to the next slide now, I'll talk a little bit about updates for allocations. Our allocation for Johnson & Johnson will decrease for the next couple weeks, and then it's expected to increase. Our Pfizer and Moderna allocations are going to be holding steady during this period. So we are getting to a point where it's going to dip just slightly, but then we're going to see quite a marked increase in our vaccine allocations and need to be prepared to deliver those vaccines through a variety of different channels. District allocations to pharmacies are about at 24% right now. And we'll see how that changes. Of course, the Federal Pharmacy Partnership Program is still ongoing as well, and we are bringing on more and more pharmacies, both through that program and to receive vaccine as part of the pharmacy partnership here in Virginia. The VaxMax system is going to be in testing, and I think will come into production shortly, and that's for improved vaccine allocation management. And some reminders to help with allocation data. Please be sure that your doses are entered promptly into any system that you're using so they are transmitted to VIS. Be sure to report your inventory in Vaccine Finder daily and complete the redistribution survey anytime you're redistributing vaccine. Please also remind providers to be doing these three things. That helps ensure that we have the most up-to-date data to use for allocations and inventory tracking. And also, as you're planning clinics, please remember to complete that REDCap survey so that we are able to develop that registry of clinics, and that is very important for us in terms of briefing both agency leadership and leadership within the COVID-19 response and at the governor and cabinet secretary level. If we go to the next slide, as I mentioned, we're going to be getting more vaccine, and one of the ways that we want to get that vaccine out into communities is through these community vaccination centers. Beginning next week, we're going to start 3 CVCs in Portsmouth, Petersburg, and Danville. These are going to be large, kind of high throughput vaccination centers, and they're really going to be managed by a contractor that has been hired. They're going to operate initially as closed pods, so appointments are still going to be required, and those are being scheduled through that vaccine appointment scheduling engine that I mentioned. Registration and vaccine administration for these clinics will be recorded in PrepMod right now. And there's talk about continuing to try to enhance PrepMod, or also potentially moving solely to VACE if it's able to actually do the registration and vaccine administration as well. More to come on that, and we'll talk a little bit more when Jessie does her VACE demo about the functionality in VACE right now and what it could look like. If we go to the next slide, we can skip that. That's just a header slide for the PrepMod update. Here on the screen, you can see metrics for PrepMod. You can see that we have 720 upcoming clinics, 838 completed, and we have well over 180,000 vaccines that have been recorded in the PrepMod system. Again, the focus areas right now are data integration with this, making sure that districts are onboarded and have access to office hours, as well as user support and adoption of the system. We're still watching very closely for that bulk upload functionality and the one-time use link. That is still not yet active in the PrepMod system. We're hoping that that will become active at some point, but again, we are planning for contingencies, and one of those contingencies is the VACE system. If we go to the next slide, just some training courses and additional office hours coming up on PrepMod. Please email Dana. She's your primary contact now for training or for support, and then copy Nippon and Sue. And a schedule will be published for on-call weekend support as well, and will be sent out. We do know that there's a lot of weekend clinics happening. That's all I have. If we go to the next slide, just again, thank you for everything. We very much appreciate it. And if Jessie Silver is on the line, she is going to be providing hopefully a quick demonstration of the VACE system. So Jessie, if you're on the line, I'll turn it over to you. And Jessie may not be on the line, so we might be able to come back to that later in the call. Otherwise, we can continue with everyone else's updates. Thanks, y'all.
Thank you, Marshall. So we'll go ahead and move next up with the modeling update with Justin Crow. Justin, are you on the line?
Yes, thank you, James. Next slide, please. Our usual background, UVA continues to create our modeling results and improves it every week with new and better data, while RAND provides third-party analysis of our data and our modeling effort. Next slide, please. The national situation, just some background, the national situation has changed. We had seen broad-based declines the previous couple of weeks. Now we're seeing just about every state in a plateau trajectory. So those declines couldn't go on forever, but they, I think they stopped a little bit higher than we had hoped, in that 10 to 20 range of cases in a lot of cases, but plateauing trajectory-wise across the state. If you look at the way that the curves are colored within each of those boxes, that shows the transmission rate that occurred in the past week as well. And you can see a bright red one there and a couple of orange as well, indicating transmission rates are about 1, or that red one is about 2. So beginning to see maybe an inflection point, or hopefully not an inflection point, but at least a flattening out of the decline that we saw nationally previously. Next slide, please. Closer to home, though, we continue to see declines in our neighboring states. Just about every state, well, I'm sorry, all of our neighboring states and Virginia are now in what our RAND, our partners at RAND describe as high caseloads. That's 10 to 20 average daily cases per 100,000 residents. We continue to see declines in all of our neighboring states. The exceptions are Maryland. The exception is Maryland, which has been flat for the past 2 weeks as well. So kind of matching what we were seeing nationally. We know that, well, I guess we don't know that, but we've seen throughout the pandemic, Virginia has kind of lagged what we've seen happening nationally. Surges hit Virginia a little later, as do declines, and so this plateau might be hitting Virginia and neighbors a few weeks later as well, but hopefully we continue the downward trajectory we've been seeing. Next slide, please. With that said, the situation in Virginia continues to improve. The scale on this has changed again. Last week it was 30 cases for the brightest yellow. Now it's 25 cases for the brightest yellow. So that kind of is a outside indicator of how the state is performing overall. We have 78% of counties have fewer than 20 cases per 100,000, and 24% of counties have fewer than 10 cases per 100,000 average daily. And instead of seeing kind of a trend where it had been moving towards the coast from southwest, it's more of a scattered look now with where we're seeing high and low cases. So next slide, please. With that said, we still remain in a lot of areas of the state well above the summer mean from last year, particularly if you're looking at, close to southwest along that sort of the I-81 corridor there, and then portions of Three Rivers, also very high compared to the average mean rate seen last summer. So just another indication that while things are declining, the actual case rates remain high. Next slide, please. This says risk of exposure by group size, but I believe we have entered the wrong map here, and what it shows is the zip code level point prevalence map. So that correlates very closely with our risk of exposure by group size, but you can see a few areas where there are very high point prevalence. The top 10 are listed there. We're still seeing high point prevalence among some of our college towns, but those are not nearly as high as they were. And we saw those spikes related to students returning to class and some non-compliance with guidance. Next slide, please. And then statewide, last week, I believe just about all of our health districts were declining and none were in a growth phase. We've kind of bounced off that a little bit. We have 4 in Plateau, and then looks like Roanoke and Chickahominy are in slow growth. Whether that trend continues, it might just be, a little bit of shifts or randomness to this, but something to keep an eye on in those local health districts. Next slide, please. As you expect, transmission rates continue to decline in most of the state. They've pretty much flat in central Virginia. A little bit of a rise in northwest Virginia. Far south west Virginia saw the biggest decline. It declined. It was above 1 last week. Now it's below 1. However, it still remains pretty close there at 0.927, and it is the highest transmission rate in the state. Next slide, please. And the time from symptom onset to diagnosis just continues to kind of tick down. We're looking at 3.4 days average for February. Next slide, please. The scale on this was changed. For the vaccine acceptance rate, it used to look like it was kind of jumped up and jumped down, but I think this scale is a little bit better. It shows how it's been basically flat, but still 3 out of 4 Virginias will definitely or probably take the vaccine when it is available to them, according to Facebook surveys run by Carnegie Mellon University. So just something to keep in mind is those Facebook surveys might not have as much penetration in communities that might be have more vaccine hesitancy, however, so this might be a bit of an overestimate, particularly for some regions of the state and some communities. Next slide, please. That said, vaccines continue to accelerate. So right now, about 16.5%, or as of Wednesday, about 16.5% of Virginia's population had at least 1 dose of vaccine, and 7.4% had 2 doses. Combine that with the 6.7% of confirmed cases, we expect the number infected to be about 3 or 4 times that. We're beginning to see significant portions of the state that should have some immunity or some protection from one getting infected in the first place, and then having a severe disease or death. And we also expect those to be concentrated in the most vulnerable population, particularly the infections, to be concentrated among those who were most likely to be exposed. Next slide, please. There hasn't been much change to the scenario, so I've left out most of those slides. I do want to point out that the vaccine rate that the UVA team has been using to project the number of vaccines, particularly the number of first doses that individuals would receive. They had previously taken the previous week's average at the county level and just projected that forward. However, that was an under projection, so this week they used an accelerated rate of 375 first doses per 100,000 persons per day, about 32,000 first doses per day. It's a 30% increase over the current rate, which kind of matches the growth rate. We are starting to channel them some better idea of what we expect going forward, so this should improve, but that is now what they're using as their base vaccination rate estimates in the scenarios with vaccines. Next slide, please, which all the scenarios have vaccines now. So just an overview of the scenarios. This has not changed, just that vaccination schedule has changed. Next slide, please. So just to highlight some of the most, I think, useful scenarios is one is the adaptive, which is the current course with that new kind of accelerated vaccination rate that we're expecting. We have already hit our peak then back in the end of January, and we see steady declines. We'll be below our summer areas there, according to this projection, maybe in late April or early May. And continued declines after that are projected. Next slide, please. And just deviations from the model's expectations last week that we saw. So using the same adaptive scenario, this is a way to kind of understand about which counties or which areas are divergent from the expected trend. So it might show where to maybe think more about variants or to keep an eye out a little bit more. Another way to highlight areas that might be more concern or bear more scrutiny. So Nelson and Highland counties stand out there, and a few other counties in the orange. Next slide, please. The other scenario I want to point out was the fatigue control. So this is the current course, but people loosen up their prevention efforts to basically the lowest level that they've seen per county throughout the course of the pandemic. So if that occurs, we would expect to see a little bit of a rise in midsummer, peaking around July 1st. So this would extend the pandemic, keep levels at or above what we saw last summer, basically through the fall, if people start to loosen their prevention measures significantly. Next slide, please. And finally, this is the fatigue control with the variant. This is the only one where we see a really large surge. Even with the variant introduced to the current course, we expect a continued decline. But if we combine fatigue control and variant B117 taking over, which is still expected by the end of March, so just a few weeks away, we could see a significant surge in the middle of summer, reaching peaks that we saw back in January, approaching those peaks. And that's even with the accelerated vaccination schedule. So hopefully we don't get there, but just something to keep in mind. Next slide, please. Of course, that accelerated vaccination schedule does have an impact. This slide, if you look at the chart on the right, that purple line is the old way, the projecting the last week's vaccination rate forward. So a very high peak expected if that were to occur with the fatigue control as well. So that would be fatigue control with the old vaccination rate, and the the brown line is what we saw with that accelerated rate of vaccinations with the variant and with pandemic fatigue kicking in. So the rate of vaccination and the compliance with prevention measures are definitely key to keep in place to control any variants that might arise and that we do expect to arise. Next slide, please. Just a quick summary of all of the scenarios right here. Next slide, please. So, and just to point out, even in that worst case scenario with fatigue control and the variant taking over, we do not at this point expect hospitalizations to exceed capacity in any region during the projection period. Next slide, please. And the usual where to get more detailed information if you are interested. That's all I have. Thank you. I'll answer questions in the chat.
Thank you, Justin. I do want to address one thing in the chat. I'm saying that there were some issues with some people being able to chat as it being open. On my end, it does show that it's open to all. I know that there was an issue that a prior meeting was having that was hosted by somebody else, so it may be a technical issue with WebEx today, but it does show on my end that it is open for all. Next up, we'll have the other PH ops, including health information, investigation, surveillance, containment, and informatics and information systems with Virgie Fields. Virgie, if you're on the call, please take the call for us.
Yes, thank you. Can you hear me?
I can. Please go ahead.
Thanks. Next slide. So I just wanted to mention that we included additional slides that were sent out in Donald's slide set that he sent out this morning that I won't be going over today. It's just due to time constraints with, we're also going over Ebola updates at the end. This is one of the slides that should have been skipped, so next slide, please. Oh, no, sorry, no. So for March 8th, on March 8th, CDC released interim public health recommendations for fully vaccinated people, a consumer-facing page for what you can do when you've been fully vaccinated, and a science brief with background rationale and evidence for the new recommendations. If you have been fully vaccinated, you can gather indoors with other fully vaccinated people without wearing a mask, and you can gather indoors with unvaccinated people from one other household without masks, unless any of those people are high risk for severe illness from COVID-19. You also do not have to get tested again, even if you have an exposure to someone with COVID-19. However, people who live in a healthcare setting or a group setting, like a correctional or detention facility, still need to quarantine for 14 days after an exposure, even if they are fully vaccinated. People who live or work in congregate settings, healthcare facility, or high-density workplace may still need to get tested after an exposure. Employees should continue to follow workplace testing procedures if in place. CDC also released updated healthcare infection prevention and control recommendations in response to COVID-19 vaccination on March 10th. In these updated recommendations, fully vaccinated healthcare personnel do not have to quarantine after exposure at work or in the community as long as they do not have any symptoms and do not have underlying immunocompromising conditions such as organ transplantation or cancer treatment. Healthcare personnel should continue to follow travel-related recommendations, and the team is working to update websites, documents, and other materials to reflect these changes. Next slide, please. For our infection prevention and control updates, again, on March 10th, CDC released those updated healthcare infection prevention and control recommendations in response to COVID-19 vaccination for all healthcare settings. This includes nursing homes and assisted living facilities, but is not limited to those facilities. CMS also released on that day updated COVID-19 guidelines and revised visitation recommendations for certified nursing homes in response to significant reductions in COVID-19 infections and transmission resulting from ongoing infection control practices and high vaccination rates in the nursing home population. Relaxing current restrictions on indoor visitation might increase the risk for transmission of SARS-CoV-2 in post-acute care facilities. However, vaccination of residents and healthcare workers can mitigate some of these risks, and expanding visitation has substantial benefits to residents. Facilities should continue to regularly vaccinate new admissions and staff and should adhere to current CMS regulations and guidance for COVID-19 testing, including routine staff testing, testing of individuals with symptoms, and outbreak testing. In addition, long-term care facility residents, staff, and visitors should still follow infection prevention and control recommendations, including adhering to hand hygiene, masking, and social distancing. A VDH press release is forthcoming, most likely today, and the team plans to update documents and other materials on the Long-Term Care Task Force website to reflect these changes. Next slide, please. VDH recommends that per the updated CDC guidance, indoor visitation could, and this is language that's used in the CDC recommendations, or should, which is what's used in the CMS guidance for certified nursing homes, be permitted for all residents except as noted below. Indoor visitation should be limited solely to compassionate care situations for unvaccinated residents if the COVID-19 county positivity rate is greater than 10% and less than 70% of residents in the facility are fully vaccinated. For vaccinated and unvaccinated residents with SARS-CoV-2 infection until they have met criteria to discontinue transmission-based precautions, or for vaccinated and unvaccinated residents in quarantine until they have met criteria for release from quarantine. Facilities in outbreak status should follow guidance from the local health department, as well as the CMS guidance on when visitation should be paused, and CMS has a section in their guidance for outbreaks. Visitors should be counseled about their potential to be exposed to SARS-CoV-2 in the facility if they are permitted to visit. And then there are additional recommendations that are outlined by CDC and CMS in their updated guidance documents. Next slide, please. For the informatics and information systems team, VEDS now has a COVID-19 variant field, a breakthrough infection field, both in the EPI section and a vaccination history block at the bottom of the COVID tab. The team also made available the Johnson & Johnson vaccine for manual entry as a vaccination event. In alignment with these changes, the team has updated the case report form and the data entry guidance for vaccinations. Next slide, please. To be determined is the timeline for geocoding of COVID-19 cases and the VEDS-VIS interface query. We hope these efforts move forward once resources for collaboration and testing are freed up. Electronic case reports from Carillion are supposed to go live this coming Tuesday. These are generated from their electronic health record system, and we'll have more information than a case report form from REDCap. The team will review this new type of message during Tuesday evening's fireside chat. Next slide, please. And finally, this table shows the number of variants of concern reported in Virginia by region and type. The total number of variants of concern reported for Virginia as of March 11th is 69, with 49 B117 and 20 B1351. And that was it for me. I'll turn it over to Jonathan Falk, who's going to give some Ebola updates.
Thank you, Virgin. Can you all hear me?
We can, Jonathan.
Perfect. So for an update on the Ebola outbreaks in Africa, in the DRC, as of March 5th, there are 11 cases, including 5 deaths. A ring vaccination strategy is being used to help contain the spread of that disease. In Guinea, as of March 7th, there are 18 cases, 14 confirmed and 4 probable, and 5 cases have been in healthcare workers. A ring vaccination strategy is also being used here. And as of March 7th, there were more than 1,600 contacts that have been vaccinated. The ministers of health from Guinea and 6 bordering countries met on March 2nd and developed a coordinated response, including increasing surveillance and screening at border crossings and in high-risk communities, as well as facilitating import regulations for vaccines. Next slide. On Monday, March 8th, CDC released their interim guidance on risk assessment and management of persons with potential Ebola virus exposure. On Wednesday, they provided an update to the guidance. Compared with the guidance from the 2014 to 2016 outbreak in West Africa, this guidance is briefer and less detailed. The guidance outlines recommendations for conducting an initial risk assessment of all travelers arriving from the DRC or Guinea. Based on the findings from the assessment, travelers are essentially categorized into the 3 groups, which you can see there in the columns on this table. The first group of travelers with a high risk exposure For example, those with a needle stick exposure or household contact of someone sick with Ebola virus disease. CDC recommends that public health monitor their symptoms daily, quarantine them for the entire 21-day period, and restrict all travel. The second category are those who were present in the outbreak area, but without a high-risk exposure documented. Public health monitoring is recommended for at least 2 additional time points, midway and at the end of the 21-day monitoring period. People in this group do not have any movement restrictions, and they are allowed to travel if they receive public health approval before doing so. And then the third group are those who are present in the outbreak country, but not in the outbreak area. Self-monitoring is recommended for this group, or public health has the option to do a check at the end of the 21-day monitoring period, and there are no movement or travel restrictions for this group. Next slide. So this slide on this table summarizes our plans for these travelers. It's similar to what CDC recommends, but there are a couple of additional points to make. In the first row, we're calling those in the outbreak area, but without a high-risk exposure setting, some risk, which you see in the column header there. For Ebola virus exposure, for those in the affected country, but not the outbreak area, we are saying that they have low but not zero exposure risk. For symptom monitoring, we are recommending those with high risk and some risk be monitored by public health, either daily by phone or through an automated text or email. And for those with low risk, we are saying that they can self-monitor. In terms of VDH paperwork, we're preparing traveler agreements for the high risk and some risk groups. And for those with low risk, we are preparing a letter that summarizes recommendations for them about self-monitoring. Next slide. So this is the last one that I have to give. In terms of guidance, we are working on a number of different documents for the disease control manual, and they are listed here on the slide. We are hoping to have the exposure risk assessment form, the agreements, checklist, and message map finalized and posted by the end of today. The step-by-step procedures will be finalized as soon as possible, likely early next week. And the quarantine order template will be sent to the AG's office for review before finalizing and posting. And yesterday, Dr. Peak gave a briefing to all hospitals that was coordinated through VHHA. The slides have been posted, and I believe they're hyperlinked in the PowerPoint here, but the recording will also be coming soon. That is all that I have. Thank you.
Thank you, Jonathan. I know the slide currently says questions and answers, but we do actually have Bob Moskoff on the line now. Bob, if you have some comments, you can please go ahead.
Can you hear me,
I
James?
can. Yes, sir.
Okay. Thanks. Sorry I had to be late. Just a couple of comments that I'd like to make. One is that the VEST, the Virginia Emergency Support Team, will open up community vaccination centers that are administered by a vendor, but oversight provided by the state in Danville, Portsmouth, and Petersburg within the next week or so. And then the VEST will continue to look at areas requiring assistance and determine what our next targets will be for that kind of effort. The VEST will also look to identify other resources, the Guard, et cetera, to support the districts. On another item, the governor mandated that the state frontline essential workers be pushed up in the 1B category. So we did analysis of that. Obviously, the majority of those folks are in the Richmond metropolitan area, and we've coordinated with Richmond and Henrico health districts, and they are going to conduct an event, may cover several days, several events around the 1st of April. But the methodology we've done to collect the identification of these folks is, rather than make unendable lists, which we did look at last week with DHERM, we've gone to the pre-registration system and had them identify themselves as workers who are dedicated to the continuity of government effort, and that they are not do work remotely. Additionally, put their place of location, including their street address. So those that fall out in the Richmond metro area, they'll be handled by the Richmond and Henrico health districts. But there are field offices for these state agencies around the Commonwealth, and so they'll fall into the catchment areas of the local health districts. And I just wanted to give you a heads up on that. I will forward the FAQs that are connected with this effort. The expectation from leadership at the governor's level is that they be pushed up into your development of your priority groups as we go forward. The timeline we're looking at, if possible, by the 1st of April. We understand that may not be possible. We are going to conduct the events, or Richmond is going to conduct those events for those in the Richmond metro area about that time. And that's all I've got. I'll send the FAQs out to the state, to the health directors, as well as to the emergency coordinators. Thanks, James.
You're welcome, Bob. You're welcome. Next up, we're actually gonna get Jessie Silver on. She was supposed to present with Marshall earlier, but we do have Jessie on now. Jessie, are you on the call?
Sorry. Yes, I'm sorry. I'm muted, and I'm sorry I was late. I also have slides, but I'm not certain that I can share my screen, so I'm happy just to chat also if that's better.
I can make you a presenter.
Okay, great. Thank you for. So I'll just go through these real quickly. I am now the presenter. Are you all able to see my screen?
Not presently.
Okay, perfect. Let me hit share. And I did invite, but a little last minute, Carlos and Suresh. Are you all on the meeting? Sorry. They might not be because we have a lot of things going on. I apologize. I've not shared on this platform before. Okay. So if Suresh and Carlos, if you're on, feel free to interject. But we wanted to present just a short introduction to a new vaccine clinic scheduling engine that Suresh's team, alongside Carlos's team, the data team, developed over the last couple weeks in response to the very urgent needs around ongoing, but increasingly urgent needs around scheduling and private links and bulk uploads and just challenges there. We became aware that local health districts are doing anything that they possibly can to get the clinic scheduled, and that it remains an ongoing issue that's a barrier to clinics. So I'll just run through this really quick. We will do a deep dive next week and offer you all a lot of materials on it so that you're able to explore it and test it if you'd like. We do have a few health departments doing internal and external pilots of it to make sure that it works. And then additionally, currently, as we speak, it is being used for the CVCs, the large vaccination sites. So it is in use. People are signing up real time right now. This is just an overview. So we're just really quickly how this whole system would work together. Where we're headed is that it's one system that has three kind of basic instances or parts. The database that is the database of the system to track everyone, to access the data around what we're doing with vaccination, to make sure that we can have targeted outreach and allocation, and use our data to drive that. A scheduling system that is in use now as a scheduling system and could potentially be an on-site vaccination documentation system such that it was used at a clinic. And then there's API between all of this. So feedback loops. Oh, sorry, I missed Viz. I was making these this morning. There would be feedback loops between all of these systems such that they all talk to each other and data in one would go into the other to reduce the manual work that everyone has been doing. So a lot of this has already been made, and a fair amount of it is being made as we speak and over the next few weeks. So this is the dashboard. A lot of y'all are familiar with this. One thing I just wanted to point out on it is that you will see some new fields. These fields are rapidly developing up here for filters. And you'll notice that the has vaccination, that's been there a while, and we're dialing in the Viz feedback for that. But if you'll notice also, there's has registered, has notification, has appointment, and vaccination is complete. So not just has a dose of vaccination, but the process is complete. These are placeholders, so that the has vaccination is not a placeholder, but the other ones are placeholders. And that's where VACE is going to feed back in shortly, so that you will know if you go into the dashboard who has received a notification, meaning an invitation to a clinic, who's made an appointment, and who has had one shot or completed their vaccination status. So just super quick few screenshots and then I will be finished. It's a system that you log in. You can sign in with your COV account quite easily. This is just one screenshot of it. Again, there'll be a deep dive, and the team, Suresh and Diraj and Tobin and others can share how you use it. But you could have different views of clinics that you can build, much like you would in BAMS or PrepMod. And some nice data viz. There's even another dashboard that shows what's happening in terms of your clinics for the week and the number of appointments that have been made, total number of appointments left, registrants who are yet to make appointments. And then you can notice here on this dashboard that with the clinics, you have, and this is in real time, you can watch it populate. So how many appointments are being scheduled, and the number goes up, people who are opting out, yet to make appointments, the supplies. So there's a lot of information that you're able to see and monitor in real time. Another screenshot. So the system does bulk uploads. So we were bulk uploading spreadsheets of thousands of people this morning. And when you do that, it auto sends an email and an SMS with private links for folks to sign up. And then it gives you all sorts of feedback on what's happening with that. So this is a different view, kind of a deeper dive into the status of each of these. So it tells you about failed emails. So you can go through and try to see if you have the correct one that you can add. It tells you if SMS did not deliver. It tells you if there's registrants without email or phone. So if you're just uploading one without the other, it just gives you a snapshot of what you're looking at. Currently with the CVCs, the call center is reaching out to folks who have not yet responded and calling them to try to make an appointment. So there's a lot of capacity for collaboration between hotlines, call centers, and local health departments. That's the same screenshot. I apologize. There is a really nice diagram that was just made, a swim lanes diagram, a process flow that shows how all of these stakeholders and systems will work together in a way that this was all designed really intentionally as one system rather than we've attempted to pull together multiple systems. But then the starting point for this was how can this all work together? Staff, tech systems, public who are signing up to get vaccinated. And for right now, I just also wanted to mention that I have started our team, but I'm leading a team to download from the pre-registration list everyone who's going to get invited to the CVCs, and then also to a lot of the large-scale pharmacy events. And the reason that I'm downloading it at a central level for these is to make sure that we don't have redundant downloads. So avoiding a pharmacy or the pharmacy team and the CVC team downloading the same list and working off of it. This way we can have one download and then divide and conquer. I'm also reaching out to in the regions where local health districts overlap with pharmacies and CVCs, reaching out to see if we can coordinate to make sure that we're not all calling the same folks, because that's been a really large pain point as well. So the schedule for this would be pharmacies or CVCs or even local health districts saying how many appointments are they going to have for the week after next. And then my team would be downloading and dividing kind of a master list over the weekend such that we could deliver it divide and conquered. And we'd take your orders. So we wouldn't be determining who we're inviting. You would tell us, this is the community I want, this is the population I want, this is the phase my local health district is in. And then we would divide to make sure that we didn't give those people to the pharmacies and vice versa. And then you could make appointments for that following week. And we would just do this on a rotating basis. So with the CVCs, when we upload into VACE on Mondays, and that invites folks to the next Monday appointment. And then Tuesdays, Wednesdays, Thursdays, Fridays, so that we have a steady state of call volume for the call center, and so that we can just monitor it daily. Sorry, that was longer than I expected it to be, but that is all I have. I'm happy to take questions, but we're probably running over. So feel free to reach out to me on email, and I can field questions for Suresh and connect you with him. I haven't checked with him if he wants a massive volume of emails. So feel free to email me, and then I will pass things on. And that's all.
Thank you, Jesse. At this time, we'll have question and answers in the chat box. If you've joined the meeting by WebEx, please type any questions for presenters in that chat box. If you joined the meeting by phone, however, please email your questions to donald.moore@vdh.virginia.gov with the subject line LHD call question. That would also apply to those that were having issues with the chat box earlier. You could also email your questions to the donald.moore email address. What we'll do is we'll monitor the chat for the next few minutes, see how chat's coming through. As we see that the questions are diminishing, then we'll make the decision to end the call at that time. Otherwise, if you're dropping off now, thank you and have a great weekend. And we'll go with that. Thank you. Thank you, everyone. I'm seeing that the chat has come to a close. We're going to go ahead and end the meeting for the day. Thank you for joining and have a great weekend.
James, don't hang this up yet.
Okay. You stop the recording because I can't hit, because I'm not host anymore. I can't stop the recording.
Rich says it stopped, but I still see the red light.
Yeah, I don't have access to it because I'm not the host. When the two of you came back on, it got kicked back over to Rich being the host.